talk to you about communication with children. And the objectives for this class discussion will be to use developmentally appropriate ways to communicate with children, describe family-centered care and communication, and discuss how nurses can effectively communicate with children. Components of effective communication. The first one we will talk about is touch. First and foremost, communication is our most important linkage between parents and providers, based on honest, caring, respect, and a direct approach. It addresses both cognitive and emotional needs of children and their families. So when we talk about touch, we talk about it's a human element that is effective from birth to adulthood. For infants, that means holding, cuddling, gently stroking, patting. This creates a sense of emotional support through these messages. For toddlers and preschoolers, they enjoy holding, being rocked, stroked gently on the head, back, arms, and legs. For the school-age child and the adolescent, giving and receiving hugs is important. Reassuring pat on the back or hand over hand. Always ask for permission before you touch your patient. Body language is important. How you present yourself and how you stand invites communication and interaction with the child and their family. If you have a closed body stance, it will impede communication and will be ineffective in making yourself available to the patient. You also want to recognize that the timing of when you're communicating with the child and the parent is important. So around the time of where there's going to be an open time, where there's not going to be a lot of distress, like immediately before a procedure, or if the child is beginning to take a nap, if the doctor is going to come back and discuss a very important lab or test result, you want to make sure that the timing of all that is appropriate and that the family is going to be willing and able to be available emotionally, physically, mentally at the time of when you're needing to discuss the most important issues about their child. You also want to take into account physical proximity and environment, because that can too affect communication. We know that children are more comfortable in their home environment, so putting them in the hospital setting is a very enormous stressor for them. So different comfort zones for physical distance. And you need to be aware of those differences and move cautiously when meeting children and their families. You, of course, want to be at eye level with the child. You never want to be talking above them, looking down upon them. You want to be kneeling towards them, kneeling at their bedside, or on the floor if they are sitting on the floor playing with them. Privacy is crucial when caring for adolescents who will not discuss sensitive information in front of their parents. You want to be respectful of them. You want to be respectful that they do not want personal information disclosed to their parents. You want to close the door behind you when you start to discuss information with an adolescent to preserve their privacy. When we talk about listening, that's the most essential component. Active listening skills will transmit into effective listeners. Being attentive, that means having undivided attention to that family and eliminate any distractions. Clarification through reflection, using similar words, addressing what was heard and content was understood. Having empathy for the family, acknowledging the feelings in the message being expressed. Being impartial, so avoid any personal biases and listen with an open mind, not being judgmental. And that includes when you're giving a shift report to the oncoming nurse the handoff should be objective and impartial. And you want to talk with children and not to them. When we talk about visual cues, we're talking about the eye connection. Eye contact is a connector. It confirms attention and interest between the individuals communicating. Children and some adults are visual learners. So for them, reading instructions, demonstrating, um, using appropriate dolls or videos or computer programs may be a way to get the child and the adult more involved in the process. You want to keep in mind your tone of voice. Soft, soothing voice is more comforting to an infant than a loud, startling voice. Infants can sense from the tone of voice if the caregiver is angry or happy. Children can detect anger, frustration, joy that voices can convey. An infant's mode of communication is through crying, by checking by needing to check basic needs such as hunger, pain, discomfort, and temperature. Cooing and babbling for them is a way of conveying comfort and contentment. Family centered communication is we need to understand that families are intimately involved in the care of their child. And we know that when they're intimately involved, the overall experience in the hospital for the child and the family is better. Create a partnership with the providers. Family centered care means the child's recovery and care is enhanced when the family fully participates. So you want to establish a rapport early on with the family and the child. Convey a genuine respect and concern during the first encounter. Be available and open to questions. Families want uninterrupted time with the nurse. So carving out a portion of your day where you say to them, okay, I'm going to give you at 1 o'clock 15-20 minutes to sit down, ask me any questions that you have. It's undivided attention. That way they know that you're present, that you're willing to answer any questions, or whatever you can't answer, you will search out for the answers for them. But them knowing that you are providing a certain amount of time for them without distraction is important. You also want to encourage the families before your meeting to write down any questions they may have. One, so they don't forget, and two, because it provides a way to develop a collaborative approach between the two of you so that nothing is being missed in the development of the care of the child. So this is a way of building the trust. It's an important way to establish and maintain a therapeutic relationship between the child and the family. You also want to keep in mind with the family that respecting their diversity. So children today live in a variety of family structures. They could be children from adolescent parents. They could be living with extended family of aunts and uncles. Grandparents could be raising them. They could be raised by lesbian gay families. So we want to keep that in mind, and we want to be respectful of that. We also want to be able to avoid any assumptions and blaming. And what do I mean by that is avoid assumptions about the core family values and beliefs of the family. Don't use blaming. It doesn't solve any problems. You want to first identify the part of the problem that each party owns and work together to resolve it. Because blaming and finger pointing is not going to resolve anything. Again, you want to remain non-judgmental in your situation. You want to listen, of course, actively. Because if you listen and understand what the other is saying, conflicts will be resolved. When we talk about communicating with children with special needs, this encompasses children with a visual impairment, hearing, neurological impairment, and also child with a language barrier. So when we talk about a child with a visual impairment, you want to obtain an assessment of the child's self-help skills and abilities. And that goes for toileting, bathing, dressing, feeding, and so forth. You want to be able to orient that child to their surroundings of the hospital. Walk the child around the room and unit several times, indicating where the landmarks are: the door, the closet, the bathroom. You want to show them where the call light is and keep it in the same spot all the time so that they know to go back to it in that same area. Encouraging a family member to stay is always helpful. Keeping the furniture in the room in the same place provides consistency and it aids in the child's orientation. Identify yourself when entering the room and tell the child when you're leaving. And carefully and fully explain all procedures. When you have a child with a hearing impairment, you're going to continue to do the same thing by assessing the child's self-help skills and abilities, going along the lines of toileting, bathing, dressing. Identify the family's method of communication, which means, do they communicate through a communication board with this child? Do they communicate through the use of hearing aids? Does the child with hearing aids? A cochlear implant? Do they use sign language in the family? And what are a few of the words used in sign language that you can use to communicate effectively with the child? Develop a communication board with pictures is most commonly used for most commonly used items or needs, such as television, cup, toothbrush, toilet. You want to enter the room, you want to do so cautiously. You want to touch the child before speaking to them so they're aware that you are present. Always face the child when speaking because some children are lip readers, and face-to-face visibility is important in that respect. Do not shout or exaggerate speech. Remember that nonverbal communication can speak as loudly as if not louder than speech. When performing a procedure, make sure that somebody is in front of the child explaining the procedure so that they're fully aware of what's going on around them. When you have a child who speaks another language, you want to thoroughly assess the child's ability in speaking and understanding both languages. You want to utilize interpreter services, especially when it comes to gaining consent for a procedure, discussing the mode of care, discussing changes of care, discussing changes of medications, because explaining any kind of new skill that the family needs to go home with in terms of like dressing change. You know, an interpreter is going to be very monumental in with that process. Use a communication board with the names of items printed in both languages. And try and learn the words and names of commonly used items in the child's language. Using familiar language not only aids in communication but also demonstrates a sincere interest in learning the language and respect of their culture. Lastly, I want to talk about a child with a profound neurological impairment. Here you want to address the child when entering and exiting the room. Gently touch the child when saying the child's name. Speak softly, calmly, and slowly. You want to ask the child questions, allowing the child adequate time to respond. Be careful to ask questions only of children who are capable of responding. Be certain that child's ability to respond to simple questions. Some children can respond yes or no questions by squeezing your hand, blinking their eyes. Be extremely attentive to any signs or gestures. That includes facial grimacing, smiling, eye movements that will convey a response to you. Signs and gestures are the child's ways of communicating. Be respectful of them. Talk to the child about activities and objects that are in the room, a special toy that they may have with them, a picture, and show them that if they can, things that they might see or hear or smell, talk to them about. When we talk about managing conflict, maintaining trust with good communication, the biggest component is determining a common goal. You want to address the common goal and stay focused on it through the entire hospitalization. You want to address any concerns or worries the family may have in an expedient manner. You want to understand the parent's perspective. It shouldn't be about who's right or wrong. You want to openly express your feelings, so an openness to communication is going to be important here. And again, you want to avoid the blaming. No point finger pointing because it's not going to resolve any conflict. When we consider the about warning signs, over-involvement is a common occurrence among nurses. Nurses must have boundaries that require constant awareness between empathy and over-involvement. Such examples of over-involvement include buying gifts for individual families and children, giving out one's home phone number, revealing personal information about themselves, making decisions for the family about the child's care. Some examples of under-involvement may be avoiding the child or family, asking to trade assignments for a specific child, spending less time with a particular child. You again want to use your words carefully. So poor choice in words may be, oh, the family's non-compliant, they're not cooperating, they're very difficult to work with. A better choice in words would be, they're partners in the care in the team process here. They're experts about their child, and which they are. Nobody knows their child best than the parents. And finally, you want to empower the family, and in doing so, it's by educating them. You want to educate the parents about their child's condition and the skills needed to care for that child. Provide support and guidance as they gain these new skills. And promote the parents' feelings of competence by empowering them, making them feel, building their self-esteem up that they can do it, that they can be skilled at doing it, and that they'll be successful at it. And finally, you want to summarize the decision. When anytime you have a team meeting and you are discussing a plan of care, you want to summarize what has been discussed and who is responsible for the follow-up of that, so that people are accountable and the follow-through is going to occur. So when we talk about infants and the developmental milestones as it pertains to emotional, language, cognitive, and the suggested approaches to communicating with them. So when we talk about the infants 0 to 12 months, when we talk about their experience is through their senses at this point. It's hearing, seeing, smelling, tasting, and touching. They're able to cry, they're babbling, they're cooing, they're using maybe single words. They're highly still dependent on others. They are responsive to their environment in terms of sounds and visual stimuli. They're starting to understand separation anxiety, which begins around 6 to 30 months, generally 7 to 9 months, and then again in the toddler age group. Their interactions are still largely reflexive at this point. They're beginning to see repetition of activities and movements, and they begin to initiate interactions intentionally. They still have a very short attention span, 1 to 2 minutes. So some common approaches to communicating with them is using a calm, soft, soothing voice. Be responsive to their cries, especially newborns. You never want to let them cry. You're building their trust with them. Talk and read regularly to infants. Prepare infants as you're about to perform care. Talk to an infant about what you're about to do with them. Slowly approach them and allow child to get time to know you. When we talk about the toddler who's 1 to 2 years of age, again, they too experience the world through hearing, smelling, seeing, tasting, and touching. They're starting to develop more language, 2-word combinations. They're starting to participate in taking turns with communicating, speaker and listener. They're certainly using the word no quite a bit at this time period. They have a strong need for security, strong need for secure objects. Separation and stranger anxiety is heightened at this point. They participate mainly in parallel play. They strive for routine and structure in their daily events. They participate in active exploration, so they love to go off and explore the environment, but they also want to know that they can come back and know that the parents are still there with them. Highly still dependent on significant adults. They have a short attention span of 3 to 5 minutes. So learning their common approaches to words that they may use, such as potty and pee and baba, maybe for bottle. Use play for demonstration. Use picture books. Be responsive to the child's receptivity towards you and approach cautiously. Preparation should occur immediately before the event and not any later than that. Extending it or telling them too soon will be too much for them, and you'll gather a lot of resistance from this age group. When we talk about preschool age, 3 to 5 years, these children are starting to develop a more expansive word vocabulary. They tend to speak in full sentences. They're using pronouns. They may use words without understanding their meaning of them. They like to imitate activities and make choices, strive for independence, but need adult support and encouragement. They learn cooperation and turn-taking and game playing. They're starting to develop concepts of time, space, and quantity. They're very much involved in the magical thinking of things, so that's still very prominent for them. And they still are very egocentric, so they only see the world through their eyes. They too continue to have a short attention span of 5 to 10 minutes. So for them, you want to seek opportunities to offer choices, limited choices of one or two things. Speak in simple sentences to them. Use picture and storybooks and describe activities and procedures as they are about to be done. Again, you want to be concise and limit your amount of explanation to about 5 minutes with them. Don't use medical jargon. Use common words that they will understand. And you want to engage in any activity, either preparing for a procedure or a test, 1 to 3 hours before the event's going to occur. About the school-age child, 6 to 11 years of age, they communicate thoughts and appreciate viewpoints of others at this point. They have an expanding vocabulary. They're starting to develop conversational skills. They interact well with others. They're beginning to build close relationships, and they understand the rules of games. They're still dependent on adults to meet their needs, but they're more becoming concrete thinking, and they're becoming more oriented to rules. They're able to process information in a serial format at this point. And so their attention span is a little bit more. It's 10 to 30 minutes in length. Again, you want to establish limits and set consequences for them if they're misbehaving. You want to engage in conversation that is going to encourage their thinking, and use medical play to get them to open up and discuss their feelings about what's going to happen. Again, you want to prepare them 1 to 5 days in advance, but nothing later than that. You want to keep it short, 1 to 5 days. And talk about the adolescent. We're talking about they're beginning to communicate now as adults. They're able to verbalize and comprehend most adult concepts. They accept responsibility for their own actions. They have a need for independence and privacy. They frequently have small group of very close friends. They're starting to question authority at this point. And they're able to think logically and abstractly. Their attention span is about an hour in length. So you want to engage in conversation with the adolescent about their interests. Do they play sports? Do they do any extracurricular activities? What are their plans for college, if any? By doing that and taking an initiative and an interest in their lives, they'll be more open and trusting of you about their feelings of what's going on in their life. You want to use a collaborative approach. You want to not talk to them, but talk with them about what's going to happen. Getting their feedback is going to be so important. They want to be part of the process. They want to be part of the decision making. You want to respect their privacy foremost. And you want to introduce anything event wise a week in advance to prepare them. Adolescents do very well with, reading or demonstrating or using diagrams or charts to express your what you're trying to do with them or what you're trying to accomplish, the end goal. It could be a procedure, what kind of procedure it is. Diagramming it out, charting it out is another visual form that they can use to understand the process. And finally, we want to talk about preparation for a procedure. So we want to talk about the younger the child, prepare them closer to the event, as we've discussed in the developmental milestones. Explain the reason for the procedure and expected sequence of events and outcome to reduce the child's fear and anxiety. Preparation is key to a successful event in the hospital. Describe step by step what the child will see, hear, and feel. Tell a child how long the procedure will last. And to relay any fears. So this is where medical play is going to come into play. Maybe coming in the day before to play with some of appropriate medical equipment for them on a doll. Getting them to talk about their fears and their worries is going to help alleviate the fear for them when they do come in for their actual procedure time. And learning about their culture is also going to be important because you're being mindful of their culture and their beliefs and their values so that you too can incorporate that piece into the preparation. Say, for example, if a child is Orthodox Jew, making sure that they have a kosher meal after when they're ready to eat their first meal. Making sure that certain, if they want to talk to a priest in terms of talking to them before they go into the surgery, or a family member wants to talk to a priest before it gets a blessing from the priest, that's being done for them, and that is being respectful of their beliefs, their values, and to incorporate that into their care at the hospital.